Hi, my name's Ruth Findlay, and in this video I'm going to be demonstrating 6 skills of airway management. So the first is going to be the lateral side position, then I'll demonstrate the triple airway manoeuvre, safe use of an oropharyngeal airway and a nasopharyngeal airway, then I'll demonstrate laryngoscopy and assisted positive pressure ventilation. This video was produced on the 24th of September 2013, and throughout all the videos I've used standard precautions, which is gloves and goggles. I'm now going to demonstrate the lateral or stable side position, and this position is to maintain airway patency. So first I'm just going to check for dangers like sharps or pens, anything that could be in the pockets that might endanger the patient, myself or my partner. So now I'm going to flex the knee that is closest to me, extend the arm that's further away, and then the close arm I'm going to place diagonally across the patient's chest. Supporting at the hips and shoulder, I'm going to just roll the patient and make sure the knee is on the ground and the arm up here is on the ground for stability. I'm now going to support the head by extending the neck and making sure the airway is open, allowing fluids to drain and preventing the tongue from occluding the airway. A common error with this is hyperextension of the neck or failing to extend it enough, and so then the airway can become obstructed. The triple airway manoeuvre is indicated in patients who are unconscious, and it's different from the sniffing position, which only involves the head tilt. So first you should position yourself at the head of the patient and then put 2 to 5 centimetres of cushioning under the patient's head. There's 3 parts: the head tilt, the chin lift and the jaw thrust. So you should put your thumb on the patient's forehead and at the same time put your thumb and index finger on the chin, around the chin, and now you just gently apply pressure, tilting the head back, and at the same time lifting the chin upwards, and this removes the tongue from the back of the throat. The third part is the jaw thrust, and this involves putting the 3rd, 4th and 5th fingers under the angle of the jaw. The thumbs apply pressure with them on the zygomatic bones, and as you do that, just lift the jaw upwards, and this makes sure that the airway is open. A common error is either applying too much pressure underneath the chin and causing trauma, or with the jaw thrust, instead of lifting the jaw up, lifting it forwards. And now I'm going to show how to insert an oropharyngeal airway. This is indicated in the unconscious patient to maintain full displacement of the tongue, and also as a bite block to support ETT placement. So prepare by getting the correct OPA. You measure with the fledge at the corner of the mouth to the tip at the angle of the jaw, and then insert this upside down. When you hit the roof of the mouth, rotate it 180 degrees and push it into the airway. So the contraindications are gag reflex and trismus. You need to be checking that there's no gag reflex, and once the airway is in, to check, look, listen and feel for air movement. A common error with this is selecting the incorrect size, and so then the airway might still be obstructed. I'm now going to demonstrate insertion of a nasopharyngeal airway. The indication for this is an unconscious patient with trismus. The contraindications are if there's middle third facial fractures, if there's significant nasal trauma, or if there's a traumatic brain injury, but there's adequate tidal volume despite trismus. The precautions are if there's CSF fluid draining from the nares or the ears, if there's basal skull fractures, and might need to be removed for intubation. So procedure for this is to select the correct size by measuring from the corner of the nose to the earlobe. So this is the correct size. Just going to lubricate it with some KY jelly, and then insert it, twisting if I need to, and pushing it into place in the larger nostril, if that happens to be one. Common error with this is selecting the size that is too large, and then the NPA might go into the esophagus. Now I'm just going to show you how to use the laryngoscope. So with the patient in the sniffing position, just tilt the head back, visualise the airway, just check that there's no obstruction in the oropharynx, and then with the left hand just grab your laryngoscope, check that the lamp is white, tight and bright, and then with with your hand, you just place pressure on the forehead to tilt that back and place the laryngoscope in the far right side of the mouth until the tip finds the molecular groove. Now, the thumb should be on the body of the laryngoscope and applying a bit of pressure downwards. You just bring the laryngoscope over to the left and visually inspect the airway. You should see the vocal cords there. So that any obstruction can be seen and then subsequently removed. The common error with the laryngoscope is failing to check that the lamp is white, tight and bright, and this causes a problem because the globe might fall into the throat, causing another obstruction. I'm now going to demonstrate assisted positive pressure ventilation with the use of the bag valve mask. So first, position yourself at the head of the patient, and you could be in the lateral side position or the supine position, and maintain the triple airway mover. Apply the rigid face mask by putting the narrow end at the top of the nose and rolling it on. Your thumb should be at the top of the mask, your index finger should be at the base, and your third and fifth fingers under the jaw to support it to the face. To ventilate the patient, gently press the bag in to about a third of the volume and ventilate the patient at 12 breaths a minute. Make sure you observe the chest for movement and be careful not to hyperinflate the patient, as this could